thank you all for four great presentations. I'd like to ask people to come to the microphones for questions. And as people are doing that, I'm going to start us off with one question um, for all of you, really, about sort of how do we fund behavioral health services in a system where the behavioral health service provision is often very complex. And I'm just wondering if people have thought about that for programs such as, weight management or smoking cessation or AYA programs and psychosocial services. How do we have a sustainable funding source for those things?
I can speak to how programs are currently funding these. The majority of the psychosocial care in AYA programs is being provided through philanthropic support. Generally, significant gifts given to an AYA program, often with the charge to develop psychosocial care within that program. And that the goal is that either the gift is large enough to sustain for quite a while, or that the expectation is that once the program is launched, that additional philanthropy can be gained. There are a couple of programs who mentioned getting grants for very specific interventions, and oftentimes this was through a research mechanism. So it was a small grant to develop and test or develop and pilot an intervention. But again, sustainability seems to be the challenge in terms of funding.
No other comments?
Thank you. I guess the on-off button is the way to do it. That confused me. So in terms of tobacco, I think that there's a range of options right now. One of the most important things to do is probably to hook people up, do an assessment, and then hook people up with existing services. So there's a lot. All states will very soon have comprehensive tobacco control programs as part of the Affordable Care Act. So, and many states have quit lines. So I think that you could, and maybe should, I don't know the answer to that, build a structure internally, but an assessment and a referral program. And in most states, there's actually very easy fax referral to the state quit lines. So that can be integrated into care without a giant infrastructure.
I guess also part of the question is about whether the psychosocial services, there are some mechanisms to bill psychosocial services through medical benefits, especially some of these behavioral health services. Also the options to bill them through behavioral health benefits. And I didn't know if people have thought about those in terms of actually not relying on philanthropic dollars or state-provided programs, but actually relying on health insurance.
I mean, I think it also has to do with the types of health insurance that are available in your community. I mean, state to state, it might vary who has private. In certain states, there's higher proportion for our teens and young adults being uninsured, and then when getting the cancer diagnosis, going into a public health insurance program. And many times it's, at least with our own local experience, you try to advocate for that, but we, really have to have that philanthropic piece. And I think also thinking about innovative technologies, about linking with existing resources. So we know physical activity is important, and we all know here about, the great work that First Descent does. And so we are working on a text messaging intervention that if a survivor chooses that they want to get physically active, then we would link them with available community resources. Again, kind of through that same mechanism of having a community advisory group, that what are services available for teens and young adults, what are the age ranges, what's your, you have to put in the zip code to say what's your catchment area. So I think exploring all those areas through research dollars, philanthropic, and kind of the challenges with the health insurance system. But it's better when you can stay on your health insurance till 26 through your parents' plan.
Other questions?
Patty Gans, UCLA. I wanted to speak to just a couple of broad issues. The one is the issue of delivery of psychosocial care. I was on the IOM report that reported pointed out the wealth of psychosocial resources that there actually are in many communities or available on the internet or other places, and the lack of connection of patients, it doesn't matter what age they are with cancer, to those resources. Many of the people we heard yesterday speaking said, well, I wish somebody would have connected me with this. So I really resonate with what Rebecca was speaking about, that every patient needs an assessment. And as an adult oncologist who's also focused on survivors and young adult survivors, uh, it's universal, but the needs are perhaps greater in this developmental age group that's quite diverse, as we already talked about. So just like, we can't really make a special case for the older cancer patient who's really the majority, geriatric oncology. There are not enough geriatricians, there are not enough geriatric oncologists. It means that every psychosocial care provider and every oncologist and every oncology nurse and every oncology social worker needs to be cognizant of developmental stage in approaching whoever the patient is that they're caring for. And I just don't think we're going to have the resources in this country to have AYA-specific psychosocial resources or even delivery programs. You described all these programs, having developed many individual entrepreneurial programs with philanthropy at my institution. It's a one-off and it's not generalizable. So I think this is getting to my next point, is this is a quality of care gap. Okay, and we want patients to be able to go through and handle their diagnosis and their treatment with all the skills and resources that are possible. And, we may not be able to change where that 17-year-old is in terms of their developmental stage, but we can support them and their family with all that we know, meaning the best, anti-nausea supportive care, the pain management, and knowledge and education and the psychosocial needs. And that's true for the 75-year-old widower who really doesn't have anyone to take him to his appointments and needs the additional psychological support and may be depressed and may be turning to alcohol, et cetera, et cetera. So that means that we need to meet the patient where they are. We need to assess their needs. We need to assess their psychosocial needs, their social. We need to know where they're coming from as a person, and not just treat everybody by a cookbook and say, this is the way I treat young people, this is the way I treat old people. So I think if we could contextualize the conversation that we're having, whether it's about physical activity and weight management or tobacco and substance use or managing distress as a quality of care issue, and say this is kind of a special case. As I spoke yesterday, this is a really vulnerable population. My passion as a cancer prevention and control doctor is I don't want to see these people get into trouble again. I want to do whatever I can to reduce their risk of second malignancies or recurrence, managing stress. In the young population, what they've told me, the young breast cancer survivors, they're exercising, they're eating well. They need someone to help them manage their stress. We did a stress reduction intervention based on what they told us because they were already doing those things. So I think tailoring whatever interventions we're going to do to where the patient is. If they're not smoking and they're eating and exercising, we need to figure out what the other thing is that we need to do. So I think if we can, instead of, say, AYA exceptionalism, I think, the PRG really brought this out as a high profile needed group that's been underattended to. That's great, but we need to integrate it into general oncology because we're never going to have all of these specialized programs to meet everyone's needs.
Thanks, Patty, for providing the answer to my question, which in part I think you did. So I represent maybe a minority in the population because I run a community-based oncology or AYA oncology program in Greenville, South Carolina. I'm Hal Croswell, a pediatric oncologist within an adult oncology community setting. So Rebecca, I was really pleased to hear, as well as everyone's presentation, to focus on the psychosocial support, but on the different models that are out there. My question in relationship to Patty's statement is that when we talk about psychosocial support, when we talk about lack of clinical trial enrollment that David mentioned yesterday, and we are so dependent in the community as you transition from pediatric age group up into the adult age group, where more and more patients are being seen and cared for and have that continuity of care through and through up to 65 to 80%, then how do we affect the AYA patients and provide these resources for them? Part of it's funding, part of it is access to care, knowledge base. My question is, as a policy for this group moving forward, does AYA stand out as a distinctive population that is a sort of a health disparity? And if AYA achieved a special designation that was similar to other health disparities, then perhaps there would be funding, and there would be access, and there would be academic community partnerships. So if anybody would speak to that, whether AYA population stands out enough that there would be special recognition for as a health disparity group.
Sorry to make me get up, so I'll sit again. So Sharon, Otis Brawley, a couple of others I can't remember, and yours truly published a paper on that. Barry, you must have set this up. So yeah, we really thought that the AYA population was a health disparity and not minorities, not ethnic groups within this cancer community. So that's been published in 2005, 4, 3, somewhere. I mean, it's maybe a decade ago. And it's good to hear it's coming back. I don't know how to impact that, how to affect that, how to implement that, but maybe policy decisions could recognize AYA as a distinct disparity or community and minority in terms of access to trials and trial participation and trying to learn. Pardon? And exactly, it's a geriatric, my age problem too. That's why I'm sitting instead of standing. So yeah. Thank you, Betty. I hope we can do for both.
I just want to state specifically that when we look at the CCOP and the changes that are happening from a research base, and if we're looking at cancer control trials and addressing some of these issues in the AYA population in a systematic fashion, then it concerns me that AYA does not stand out with a movement towards prevention, especially in the survivorship population, secondary malignancies. Then my concern is that it will, as the research bases get cut from 53 or so down to 30 plus, then we're going to lose access to this this community-based population, which is rich for study. So, thanks.
Another question?
One of the things we're doing, and I think that I would love to hear some responses to that, is and thank you so much, you guys are amazing. The idea of this universal assessment. We are doing an assessment using the resilience model now with many, many well-validated measures. They are online, easy to do, very user-friendly, and the kids don't mind doing them. They're remotely available because we're doing multi-site studies. What I'd love to hear is the interest in pulling together a group to look at those measures that everybody is doing, because I do think that that's a place to start with this universal assessment to begin with. Our plan with some recent funding from St. Baldrick's is to begin to look at how to convert that data into something that is user-friendly for our providers to introduce at diagnosis, because I do think that these survivorship issues start at diagnosis. I think one of our AYA yesterday talked about, if you take care of me during my treatment, then I'll be fine in survivorship. I'll come back to you and talk with you. But if we could begin to look at a comprehensive set, I'm not talking about just this minimum stuff, because I think we need to know a ton more about spiritual perspective of these kids, all sorts of things. And the kids fill this out like you do any kind of other workup. If we could do that kind of thing, have it, embedded in cooperative groups, and all of our AYAs, participate in that, think of the outcomes that we could have, and perhaps have designated times when they're off complete treatment, they come back for their first survivorship thing, and then we have that longitudinal data, a huge database for that. We've got the infrastructure with our cooperative groups to do that.
It's interesting that you bring this up because this is not the first time that this topic has actually come up since we got here yesterday morning, that these conversations have started. The other good news is that I believe that I've had this conversation for several months now, maybe a year, with folks. So clearly it's time that we do something about it. When I spoke with our interviewees on the phone, several of those sites also said, well, what is everyone else doing? And we're doing this, but I wish that I knew what they were doing. Or we found this tool, but I don't know what anyone else is doing. So I do feel like we're ripe for this kind of growth and collaboration. And you know, oftentimes that's the challenge, is to engage and activate people and sites to want to collaborate. But we're there, and now it's a matter of figuring out how and who's going to pay for it, and there's some logistics to work out. But I clearly the interest is there, and clearly the need is there.
So I don't think the logistics are that expensive when you look at doing that online, having the kids have access to computers and internet. Most of them do. They can do that at at their first appointments. We do all the other workup, so why not? So I don't think that that's an issue. But the other comment I wanted to make was in relationship to the chaplaincy and the spiritual perspective piece, because I do think that that's something we don't talk very much about here. From my resilience model, that is a driving force for the kids. All of our kids in our study, that is one of the major significant drivers for influencing family environment and for influencing hope-derived meaning, influencing their resilience and their ability to rise above the experience, lots of things. So that's an area I think is very, very neglected. Betty Farrell is a person at City of Hope who's done a tremendous amount of work in that in the adult population and has some good models for that I think we should be looking at as well. So thanks for letting me just kind of talk, but it's...
So there's two more, it looks like there's two more questions. We have a couple more minutes, so let's try to get both of them in.
I'll be real quick. I'm Katie Donahue from NYU. There's, I guess, kind of piggybacking on that, the idea of engaging the survivor from the time of diagnosis brings up the topic of prehab. I know it's something that's been talked about, like, are there exercises, are there something that, the patient can do from the time that they're diagnosed to sort of, for as good as they may or may not be feeling at that time, that would, set them up for better health behaviors in the future. And I think there's a program called the STAR program. And I just wanted to get, the panel's, feedback, or if anybody knows much about that, what the literature is, what the support is, et cetera.
I'm not exactly sure what the body of literature says, but I can appreciate that comment and how important early physical therapy might be for some patients that need it in terms of setting them up for better health down the line. So I think that's definitely something that those referrals need to happen through the course of treatment.
And in tobacco, I know some programs that are doing that, especially in the adult space, and it's really important, actually. I think people do much better in their treatment if they're not smoking. Surgery outcomes are better. So if that could be integrated, that would be fantastic.
One more question?
I'm Wendy DeMarc-Wanafried. I'm from UAB. And getting back to the idea of lifestyle behaviors, because they are important, and the patients do say that they want these services, not just stress, and they do want to have some sort of directed attention. The STAR program is more aimed toward an adult population. So if indeed you had that, it would have to be adapted, I think, to this population. And then getting back to the AYA and trying to discern these behaviors and the trajectory of behaviors. Like Karen, you commented on substance abuse and tobacco. Do we know how that changes throughout the trajectory? Were these kids tobacco users, or did they use substances before their diagnosis, and then this is a means of coping? Do we have any do we have any idea about what the trajectory is there?
AYIs, none at all. I mean, they're just really, there's prevalence data and that's it. So this is a huge area for data collection. There's just really nothing.
Mm-hmm. Yeah, because I think that that would be so important to understand not only the trajectory of what's happening in the patient, but then what's also happening in the parent too. You know, I think we know a little bit more about the younger age group, particularly about dietary behaviors that kids will use I won't say use, it sounds very negative, but children that are at a certain age developmentally have not set their dietary behaviors yet. And they will use whatever tool at their disposal to eat more Twinkies.
Twinkies are still around.
And Twinkies are now still around. You know, and I think that sometimes the cancer diagnosis kind of gets itself wangled around in that, and kids really develop bad eating habits during the time of diagnosis. I think AYA, however, we have to, the point was made that this is we really have to target developmentally. And, you know, the same thing goes for eating behaviors. So I think AYAs have already set their eating behaviors, but certainly I can see I'm going to get cut off, so let me just make off. I'll self-regulate here. But to get these programs so that they promote exercise and diet in a developmentally sound way, and to understand the trajectory in the parent, because this is something that's really important.
Can I just add one quick
Karen,
comment
before
to that?
Wendy's cut off and we go for Twinkies ourselves, I've got to add something to what Bernard said, and this is a really good upbeat closure point for the morning session. There is increasing evidence, at least level 2 evidence, and emerging clinical trial evidence in some randomized trials, that exercise, physical activity, is an anti-neoplastic agent, that it not only improves quality of life, but it prolongs survival, as shown very well in level 2 evidence, observational studies in breast cancer, colorectal cancer, prostate cancer, the big cancers where you can do these studies, and emerging evidence in ovarian cancer and 3 or 4 others. It's strong evidence, and on the laboratory basis, there are multiple mechanisms that would explain that. I've even heard adult treating oncologists say, if I'd known this, I would have prescribed exercise instead of tamoxifen or Falfori or Folfox for SEB. So there's some really good evidence. It's still early, but I would definitely anticipate, and Wendy, you're part of that, aren't you? I mean, there's several of us in the room. It's more than just quality, it's quantity of life.
Karen, do you want the last comment?
Just going back to Wendy's comment, I was going to say that this issue about the uptake of substance use behaviors and the experience of cancer treatment, cancer diagnosis and treatment in AYIs is critically important. There's been some work in general college population where you see, you know, this really high uptake of substance use behaviors as your freshman, and then it kind of dissipates. Students who come into freshman year with an experience of post-traumatic stress or trauma of some sort have a much slower rate of decline and a higher use rate overall. And so it seems to me that really digging into that as it relates to the cancer experience would be incredibly important to understand how to best approach it in many ways.
Thank you all. So we have a break until 10.